So it's my pleasure to have been asked to give you an update on what our CIHR team is doing in terms of imaging pathology fusion. And as Aaron said, Eli and I are going to be presenting this to you together. I'm going to be leaving most of the meat to him, but we're really part of a much larger and highly multidisciplinary team. And this is part of the team, but you can get a sense of just the number of disciplines involved in this endeavor. And you know, without all of this complementary expertise, nothing that we're going to show you today would be possible. And specifically for some of the results that you're going to see today, involving fusion of pathology to MR and to PET imaging. I want to specifically thank Dr. Cesare Romagnoli, Dr. Rina Rashinsky for reading the images, the PET, the MR, and then our pathologists, Dr. Madeline Musa, Jose Gomez, and Dr. Mina Gaid for all of their hard work on pathology annotations. Eli and I are a computer science engineering background, and you know, without this complementary medical expertise, we'd be pretty lost, actually. So to dive into kind of the high level on the workflow in our study, just to give you the backstory to what Eli is going to describe later. What we have in terms of what we're doing with each of our study subjects. So our study subjects have pathology confirmed, biopsy confirmed prostate cancer, and are destined for radical prostatectomy surgery before they're recruited into our study. And when they're recruited into our study, they agree to undergo quite a battery of in vivo imaging pre-surgery. They get multiparametric MRI, 3D ultrasound. They get structural CT perfusion, and starting very recently, we've been collecting 18-fluorocholine PET CT from these patients as well. So we get quite a battery of multimodality imaging from each of these patients prior to going to radical prostatectomy surgery, after which the prostates are formalin fixed and histoprocessed, digitized at high resolution. And what you're seeing here, these little colors are the careful annotations of the pathology that are done by our team, indicating the foci of cancer and also the Gleason grade, so the aggressiveness of each of the foci that are found. And so we get this collecting this very rich data set from each of our subjects. And the objectives of this part of the team grant are to perform a multimodality registration, not only of all of these different imaging modalities to each other, but also to the pathology imaging that's acquired, in order to establish some kind of correlation between one or more of these modalities and the locations of cancer, and we hope the aggressiveness and Gleason score of the cancer that we find on pathology, with the ultimate aim of being able to predict what we see over here in the new patient based on some combination of imaging modalities, you know, in order to better guide 3D guided biopsy and possibly focal therapy as well. So the registration problem that we need to solve turns out to be pretty challenging for a variety of reasons. I'll just give you a little tour of the reasons. The first is that we get various distortions to the prostate during in vivo imaging for a variety of reasons. One, for example, here in MRI, you can see the endorectal coil is placed on the posterior. This is the rectum here. Here's the prostate. And it's causing compression of the prostate along the AP, expansion along the LR, quite a distortion due to that coil, an inflated sheath around the coil. On ultrasound imaging, you get kind of a different kind of distortion due to the probe. CT imaging, you get no such distortion. The process of formalin fixation causes shrinkage and differential distortion, as does paraffin histoprocessing and microtome sectioning. So all of these deformations need to be corrected in the registration of imaging to pathology with fine scale accuracy. In addition, we have a slice orientation issue. So, you know, we collect a histology image approximately every 5 millimeter, in fact, every 4.4 millimeter. So these images are very rich in information within each plane at half micron per pixel, but quite sparse out of plane, and they can be cut in normal clinical process. They're kind of cut by hand and by eye. And so if this cube is intended to represent the sort of in vivo imaging axes, you know, we could have them cut in this orientation. We could have them cut in this this is a bit extreme, but it can be some other orientation, and so we have this issue to deal with as well, the orientation of the cut with respect to the in vivo imaging coordinate system needs to be corrected for. And so I'm going to pass it off to Eli now, who's going to describe for you some workflow modifications that we've made here to accommodate this registration, some 2 registration methods that we've developed for doing this fusion, and then he's going to give us a tour of 3 cases that we've pulled out and done some fusion on that we found interesting, including our first case of a patient that we've imaged with 18-fluorocholine PET-CT, which to my understanding is in fact the first 18-fluorocholine PET-CT prostate image collected in Canada, and we're going to be able to show you the correlation of the signal in that image with the corresponding pathology. So I'm going to pass it over to Eli to pick it up from here.
So in order to address this registration challenge, we approach the problem from 2 perspectives. The first is to carefully control the slicing of the prostate so that we collect the histology from the location of a known in vivo imaging slice. This makes the challenge of the 3D reconstruction simplify down to a set of 2D registration problems within that plane. So this is a method that works, it is accurate. Unfortunately, it's a tedious process that's very operator dependent. So we've also moved to work from the other directions, allowing the histology to be cut from using the normal clinical process, and we're able to reconstruct the 3D spatial orientation of the histology within the in vivo imaging slices so that we have registered imaging and histology. This method is also accurate. It has a more challenging 3D reconstruction, but this comes with the benefit of a much shorter process and a much less operator-dependent one. Both of these processes rely on 2 things that we're doing in our lab differently. The first is that we collect ex vivo images, so images of the prostate after it's been removed in surgery. We take MRI images and we add strand-shaped fiducials to the outside of the prostate that allow us to have information about the spatial locations of these strands, both on histology and on MRI, because these fiducials are designed to be visible in both. So I'm going to talk in a little bit more detail about this latter method. The approach that we're taking is to reconstruct these histology slices into the ex vivo image. And by that I mean find the location within the ex vivo image that contains the same tissue as that was sampled for histology. And as a second stage, we'll be doing 3D deformable registrations of the ex vivo image back to in vivo imaging for correlation. The way that we identify these histology planes is the fiducials that we've added are visible on the histology and also on the MRI. So if we look at a slice of MRI, and you can see this cutaway in our surface model here, you can see the configuration of these matches. And if I play this video, you'll see that this configuration changes as we look at different slices of the MRI. So by matching the configuration on histology to that on a particular MRI slice, we can identify which slice in that MRI contains the same tissue as the histology image. And once we've done that with all 3 slices, we have a picture like this, where we have histology reconstructed into 3D and simultaneously co-registered with a 3D image that we can use for registration. The accuracy of these methods is really important for doing correlation of histology back to the imaging. We have to know how reliable these registration methods are. So I'll present some results about that. The first method that I talked about, where we collect the histology from known imaging slices, has a mean target registration error of about 1 millimeter. What that looks like on imaging, you can see by comparing the MRI with the co-registered histology slice. And so if I can direct your attention to anatomical features, so this is BPH, and you can see tracks running between BPH regions. And if we look at the MRI, you can see these same tracks and the same BPH consistent between these. So you can see this registration has high fidelity. If you the deformation that Aaron talked about is actually quite significant. So this is the deformed histology image, and this is the original image. So you can see that that registration had to account for a lot of deformation due to some of the chemical processes and also due to the endorectal coil that would be pushing up the posterior of the prostate. For the second method that I discussed, where we retroactively reconstruct the histology into 3D, we measured a mean 3D reconstruction error that's sub-millimeter. And this is measured as the target registration error between histology and that ex vivo image that I spoke about. What this looks like in terms of imaging, we can see in these qualitative results where we have the histology and the co-registered ex vivo MRI representing the same tissue. And you can see a number of features that are salient on the T2 weighted and the T1 weighted imaging marked with arrows here. And you can see those same anatomical features, some that are about 1 millimeter in size, that agree between these three images. So now I'd like to move on to using these methods to investigate 3 different cases of patients that have gone through our workflow to look at the in vivo imaging and what we can learn from histology. So this first case, we have the annotated histology here, a T2 weighted MRI, and a dynamic contrast enhanced MRI. And on the T2 weighted MRI, you can see in this box there's a hypointensity here relative to the contralateral side, and that's suspicious for prostate cancer. That's the characteristic signature of prostate cancer on T2 weighted MRI. If you look at the dynamic contrast enhanced image, we have a rapid wash-in of contrast in this region. And if we look at the ground truth from histology, we see that there is in fact cancer focus in that region. And it's interesting to note that in the region where we see the darkest of the hypointensity and the strongest rapid wash-in corresponds to a region in this cancer focus that has a more aggressive Gleason 4 cancer relative to this blue region that is the less aggressive Gleason 3 cancer. Our second case paints a different picture. So here we have a cancer focus on the patient's right side there. And so if we look at the T2 weighted MRI, we'd be looking for a hypointensity in this region. And we don't really see any hypointensity, even when we know that there's a cancer focus in that region. Similarly, on the dynamic contrast MRI, we would expect a rapid wash-in in this region, and we don't see that. This bright spot here is an artifact due to the endorectal coil. So in this case, the MRI would have been very challenging to identify this cancer focus. Our third case is somewhere in between the two. And if we look at the T2 weighted MRI, we see hypointensity here and here, but there's really no corroborating evidence on the dynamic contrast MRI. There's no rapid wash-in that we're seeing here. So the suspicion of this would not be as high because there's no corroborating evidence. Now, if we look at the co-registered histology, we actually see 3 cancer foci. We see the two that there would have been some suspicion for down at the posterior, but there's this large focus of cancer on the anterior of the prostate. If we look at the T2-weighted MRI, that would correspond to this region here. And if you look carefully, there is a slight hypointensity, but because this is in the context of the transition zone, which is characteristically dark on T2-weighted MRI, this would have been very challenging to see from the MRI alone. If we look at the region, there may be a subtle rapid wash-in of contrast, but again, distinguishing that from the surrounding tissue would have been very challenging on MRI. But for this patient, we've also collected F18 choline PET CT imaging. Now, to orient you, this is the CT image. The head of the patient would be off to your right. The feet of the patient would be off to your left. This is the bladder here. We have seminal vesicles here. The prostate would be outlined right about there. This is the pubic bone here. If I overlay the PET on this image, you see two strong hotspots here. This in the prostate, and this would be anterior in the prostate near the apex, and this is posterior in the prostate near the apex. This one here has an SUV max of 5.4. This one has an SUV max of 3.5 relative to a background uptake of 2.5 in other parts of the prostate. And that SUV max is indicative of where the choline was uptaken by the prostate. Now, to give you a sense of the 3D nature of these foci, we'll rotate around to an axial view. And you can see that this anterior focus is near the midline of the prostate, and the posterior focus, there's sort of spread out along the posterior wall here. Now, if we move back to our histology, we can see this near the midline of the prostate on the anterior side, on this apex slice of histology, we see, this is the most inferior mid-gland slice of histology. We see this focus that spatially corresponds with that hotspot on the PET, and we see these posterior foci that correspond to the posterior wall that we saw in PET. So I'll zoom this up here, and to give you a sort of a sense of the 3D nature of the disease on our pathology, I'm going to rotate this around, and we're going to look at this mid-gland slice as well as one slice of the apex that's cut perpendicularly so that we can see the 3D shape of this focus. And so here you see this focus is extending right into the apex of the prostate, as well as being visible on the mid-gland here. So bringing these modalities all back together, we have the MRI images, and if we were, for example, looking to target biopsy towards the more aggressive foci, or if we were looking to do focal therapy, identifying targets on an MRI alone would be challenging. There's some evidence for cancer in the posterior wall, but there's no corroborating evidence from the diffusion contrast image. And this anterior focus is really subtle and would be really challenging to identify on either modality. But when we look at the PET image and reconstruct the slice of the PET image that has the same orientation as the histology that we're about to look at, and we've constructed this using the methods that we've developed for co-registration. When we look at this slice, we see corroborating evidence between the PET and the MRI. So we see a hotspot on the anterior that could direct the focus of someone making contours towards the anterior, where they might see these subtle signs of prostate cancer on the anterior side. And similarly, the posterior focus here would be corroborating evidence for this focus, suggesting that it may be worth targeting both the anterior and the posterior wall in this region in the prostate. And if we bring back the histology, we see that, yes, in fact, the corroborating evidence that we see on PET and on MRI align well with the confirmed cancers that are identified on the pathology. So to sum up, we have, in our team, we've developed tools for reconstructing histology into the in vivo imaging space using a prospective method with registration errors that are about 1 millimeter and a retrospective reconstruction with errors that are sub-millimeter. We're now moving towards using these tools to investigate in vivo imaging modalities. We can look at these both on their own as they relate to prostate cancer and also in conjunction to look at incremental benefits of adding multiple modalities to look at the prostate cancer distribution as well as the grade.